Hello, everybody. My name is Michael Schiman. I am a nurse practitioner at Spectrum Health Lakeland Neurology. Tonight, I'll be talking to you guys about migraines primarily. I'll talk a little bit about a couple of the other headache syndromes that are out there, and then the different treatment options for migraine. Thanks for joining me. We will have the option of posing some questions. If there's anything you want to ask, there is a little Q&A icon at the bottom of your screen. There's on the right side, there's the mobile version or the desktop version, and we'll get through what we can. I probably won't have time to answer any questions about specific headaches or your own individual health concerns, but if you've got a general question, I am happy to go over those. All right, so first let's talk about what migraines are. So migraines are a moderate to severe headache. They last for a fairly long time, up to a few days, between 4 and 72 hours. They generally start on one side of the head. Not everybody's do, but a lot of people start unilateral or one-sided. The pain is generally pulsating or kind of a throbbing type pain. They generally make people want to avoid their everyday activities like walking, climbing stairs. Most of the time when people get them, they want to just go lay in a dark room, not have anything going on around them and wait for it to pass. They generally have associated nausea and or vomiting that occur with them. Not everybody gets those, but they are fairly common symptoms. Often people get photophobia or phonophobia, which means sensitivity to light or sound, and they can occur with or without an aura. An aura is kind of a warning symptom that happens before the headache. These symptoms are reversible, so they're not a permanent symptom. They come on. Often they're visual auras. Most often we see those. We can see sensory auras. You get a weird smell or hear something. Speech changes, motor changes. So there's different things that can happen. Migraines are more frequent in younger adults. We tend to see them start in the teens, 20s, 30s. Occasionally they start later in life, but more often they start in younger adults. We do see them a little more often in women than men. And they're certainly debilitating. Migraine back in 2016 was the second leading cause of disability worldwide. So they're a serious problem and lead to a lot of days of missed life. Next, migraines, we kind of break them down into chronic versus episodic. So chronic migraines are headaches that occur at least 15 days per month for at least 3 months. These don't necessarily all have to be migraines. We can see a mixture of migraine and tension type headaches. We'll talk more about tension headaches on the next slide. And like I said, greater than 8 of those headaches do have to be migraines to fit the criteria for chronic migraine. Episodic migraines are less frequent than this. Really, it's between 4 and 14 headaches per month is what the definition of episodic migraines are. And we treat them a little bit differently overall, similar treatments. There's some options that are only available for chronic migraines though. There are different subsets of headaches. One of those is menstrual migraines. We see those fairly often. These are migraines that are associated just with the menstrual cycle, right before the period, during, or just after menses is when we see those. Tension headaches are the headaches that most of us have had. You have a stressful moment. These are kind of the everyday headaches, or the, again, there's different terms that people use for these. Most of the time they're fairly short-lived compared to migraines. Sometimes they do last for days at a time though. Instead of being a one-sided headache, they're often a band-like pain, so kind of like a headband around your head. They tend to be more of a pressing or aching pain versus that throbbing, pulsating pain that we get with migraines. They tend to be more on the mild side of things, whereas migraines are more severe. They don't get worse with regular activities, so they don't seem to, most people don't get aggravated by going up and down stairs or things like that. We don't see nausea or vomiting with them. Some people do get sensitivity to light or sound with them, but not all that often. And then next, we'll talk about cluster headaches. Cluster headaches are much more severe headaches, and these are kind of a unique subset of headache. They're not all that common. We only see about 100 or so per 100,000 people, so about 0.1% of the population get these. They tend to affect men a little more than they do women. They tend to happen a little bit later in life, like 40s, 50s, sometimes earlier, sometimes later. And then there may be a genetic component. Occasionally there's families that we see these run in. These tend to be a little shorter, so they last between 15 to 180 minutes or 3 hours, and that's when they're untreated. The pain is severe, as I said before. It's generally one-sided, kind of around the eye. So orbital, periorbital, in the eye, right behind the eye, in the temple region. They have associated autonomic features, which are a set of symptoms that happen on the same side as the headache. Those can be redness of the eye, tearing from the eye, nasal congestion, nasal drainage from, again, the same side that the head's hurting on. We can see eyelid edema, or kind of puffiness, swelling of the eye. There can be forehead or facial sweating. Sometimes we can see the pupil constrict on that same side, and there can be a drooping eyelid or eyebrow with them as well. Oftentimes people want to pace, or they feel restless or agitated with them, whereas with migraine, people tend to want to go lay down. With cluster headaches, people tend to pace the room. They can occur once a day up to 8 or more times a day. Most of the time we see episodic cluster headaches. It's pretty uncommon to see chronic cluster. Episodic, they last for 7 days up to a year, and then there's a pain-free period of 3 months. A lot of times people will have them, they may go away for an extended period of time and then come back later in life. But as I said, they're pretty debilitating. People have very, very severe pain with them. So next we'll talk about why migraines actually happen, and we don't 100% know. So there's different theories out there as to what's going on, and we've certainly learned more about them in recent years, but we still don't 100% know why they happen. There's thought to be this primary neuronal or nerve dysfunction that causes kind of a series of changes to our brain that makes it more likely for migraines to occur. So initially we have this thing called cortical spreading depression. So this wave of nerve depolarization or nerve firing spreads across the cerebral cortex, or the surface of the brain. And that's thought to be what causes an aura for some people, so those kind of sensory changes before the headache. It activates the trigeminal nerve, which is one of the nerves that kind of sits at the base of the skull. Part of the reason sometimes people with migraines get neck pain, that nerve kind of sits back there. And it potentially alters the blood-brain barrier. So our brain has a protective barrier to where certain things in our blood don't cross into the brain, which keeps toxins and other things from affecting our brain tissue. So it's kind of a backup plan that's there, but it potentially alters that. When that trigeminal nerve gets activated, this leads to, again, that pain in the front of the head as well as the back and upper neck. And it causes potentially some release of some different chemicals or vasoactive neuropeptides, as my slide says. These are basically chemicals that increase pain, and they affect our blood vessels in our brain. So substance P, calcitonin gene-related peptide, neurokinin A, and there's probably others that we just don't know about. Those are some of them. Next, it leads to sensitization. So it increases our sensitivity, basically, and this causes nerves to be more responsive, so they tend to be more irritable. It leads to that throbbing pain, worse pain when you're coughing, bending, doing those everyday activities. hyperalgesia, which is just an increased kind of pain response. And then we can sometimes see this thing called allodynia, which is pain with a stimuli that wouldn't normally be painful. So like brushing your hair, just simply touching your head can be painful with migraines. The activation of that trigeminal nerve bundle can sometimes lead to some changes in our serotonin. Serotonin is one of the chemicals that's in our brain. It's a neurotransmitter, and it is one of the ones that affects anxiety, depression, things like that as well. When we have enough serotonin, we feel calm and happy, but it also has some effects on our pain control. So when there's potentially not enough of it, pain isn't inhibited, or it's easier for us to feel pain. And so again, there's potentially a role of serotonin. I mentioned this thing called the calcitonin gene-related peptide, and from here on out, I'll just call it CGRP because calcitonin gene-related peptide is kind of a mouthful. And so a peptide is basically a piece of a protein, so that's what proteins are made up of. And this specific peptide acts as a potent vasodilator, so it causes dilation or opening up of blood vessels, which in turn contributes to some of the pain that we feel with migraines. It causes some of that trigeminal pain and also causes inflammation. There is a genetic component to migraines as well. There's multiple genes that we've found that seem to run in families of people who have and suffer from migraines. It is 3 times more likely to have migraines if you've got a family history of them. So it's a pretty common story when I sit down with somebody and they say, oh yeah, my mom, my aunt, my grandma, my son, my daughter, whoever has migraines, and sometimes there's a very strong family history of that. So there are some kind of non-pharmacologic or non-medication things that we can do to help with migraine. Certainly stress plays a role in a lot of people's headaches. So doing things to minimize stress, and I know that's hard in our current world amid a global pandemic and everything else that we're dealing with. So it is understandably hard to do that, but reducing stress as much as possible, doing different activities like exercise, yoga, therapy, cognitive behavioral therapy, biofeedback, things like that can be helpful. I did note here that sometimes exercise can make migraines worse, so keeping that in mind, but generally speaking, exercise is helpful. Some people find relief with heat or cold, put a hot compress or cool compress on. Having good sleep schedules and good sleep hygiene is absolutely important for preventing migraines. If you're not sleeping well, not getting enough sleep, interrupted sleep, things like that, that can make your headaches worse. I noted here that sleep apnea can sometimes contribute as well. A lot of times we'll see wake up headaches and other things associated with obstructive sleep apnea. So if that's there, if you're a big snorer, screening for that and treating it can help prevent some people's headaches. Eating routine meals, not skipping meals, and then avoiding triggers. And a lot of people who are on this probably have migraines and probably know what some of your specific triggers are. I've already talked about stress, not eating. Occasionally a specific odor. I'll have patients that tell me, oh, a certain cologne or smell of gasoline or whatever triggers a migraine. Sometimes neck pain can lead to migraines, smoke exposure, and that can be tobacco smoke or other smoke. Sleeping in late or sleeping too much can actually make headaches worse. Nicotine is certainly a culprit. So quitting smoking or other tobacco products is reasonable. Some people notice changes with bariatric pressure, weather changes, bright lights or fluorescent lights or sunlight can sometimes trigger people. Sometimes alcohol can be a trigger, nitrates in food, aspartame, artificial sweeteners, MSG, the salt that's in processed foods and some restaurant foods, caffeine in excessive amounts can trigger Trigger headaches, chocolate can be a big trigger. And then tyramine is a substance that occurs naturally in a lot of foods. Most of them are things that are fermented, aged, cured in some way. So like cured meats, cheeses, sourdough, sauerkraut, etc. And there's certainly lists of those foods on the internet you can find. So as far as pharmaceutical treatment of migraines, we kind of break that down into acute medications or treatments that we use to treat the headache once it's there, and then preventative treatments, so medications to take to keep you from getting the headache in the first place. So certainly simple analgesics like Tylenol, ibuprofen, those types of medications have their place, and for a lot of people those work well at stopping the headache once it started. There's a prescription medication called triptans, drugs like sumatriptan, naratriptan, which are Imitrex, Emerge, rizatriptan. There's, I don't know, 6 or 8 drugs in that class. And those are intended to be taken when you get the headache. They tend to have a pretty quick kill, which is nice. So you get the headache resolved fairly quickly with a lot of those. They do have potential side effects, and certainly if that's something that your provider feels is appropriate for you, they can go over those, or if we ended up seeing you, we could. Some people get some benefit out of antiemetics or nausea and vomiting medications. There can be some benefit to those. And then there are some new drugs on the market called CGRP antagonists. So what that means is they target that CGRP peptide that we talked about a few slides ago, and basically go in and knock that protein out once it's bound. Those are pretty brand new within the last year or so, but they're a nice new tool that we have that wasn't available before. On the subject of acute treatment, we want to avoid medication overuse. So if anybody's been on a triptan, they've probably noticed that it comes in a pack of 9, and that's because using more than 9 doses of anything to treat an acute headache, we can run into this problem of medication overuse headache. And that's, when you're, again, using more than 9 doses, and it can be Tylenol, it can be Excedrin migraine, it can be a triptan, it can be a narcotic, it can be, any of those, and it actually gets you in the cycle of medication rebound, where you take something because your head hurts, headache comes back, you take something else, and you just get in this kind of nasty cycle. So trying to avoid more than 9 doses a month is important. There's certainly people who have more than 9 headaches, so what do we do for them? And that's where preventative medications come into play, or again, potentially, treating underlying sleep disorders or other issues that may be there can be helpful. There's kind of 3 classic groups of medications that we use. So antihypertensives or blood pressure medications, anticonvulsants or seizure drugs, antidepressants or depression medications. There's CGRP monoclonal antibodies out now, and those are also fairly new. Those are specifically targeting that peptide. And then Botox, and Botox is indicated just for chronic migraine. It's not indicated for episodic migraines. You have to have at least 15 headaches a month to qualify for that. Again, 8 of those have to be migraine, 7 of them can be other headache types. I guess one other thought on the last slide, and you don't need to go back, but sometimes we do use triptans in treating menstrual migraine. We use them kind of as a preventative. We can dose certain triptans twice a day around menses to help prevent menstrual migraine. So it's kind of a subset of that, but generally they're used as abortives. So Botox has been around for a number of years for cosmetic reasons. It was kind of discovered by mistake with treating migraine. Patients were getting it for their wrinkles and would come back in and say, hey, my headaches are better, what's the deal? So the drug company ultimately started researching it and figured out that, hey, there is something here. Over the course of multiple trials and a few years, they figured out that it's helping prevent headaches. as far as I'm aware, we still don't 100% know why that's happening. It is likely acting on some of those chemical receptors that I mentioned in earlier slides, like potentially that CGRP receptor, maybe some of the other pain receptors as well, and helping block some of that. At its most basic level, it's basically relaxing nerves, and so maybe there's some relaxation of muscles, but again, we don't 100% know why it works, but it is fairly effective. As I said on the last slide, it's only approved for chronic migraine, so you have to have at least 15 headaches a month. We give it every 12 weeks, so it's administered in the office, just shy of every 3 months. If we give it more often than that, it tends to become less effective. It is 31 injections that we give, so it's not just a shot in the arm or something, but it's fairly quick. We give 5 units or a 0.1 milliliter, which is a small amount, into each site. And again, they came up with those sites over multiple drug trials to see what was most effective. It's got fairly limited side effects, so most of the time it's tolerated quite well. We can sometimes see high blood pressure with it. We can see worsening of headaches in some people. It's not common. Sometimes if we give it a little bit low above the eyebrow, it can cause a drooping eyelid or eyebrow until it wears off. There's a spot, if I give it too high, it can cause the eyebrow to kind of point up, almost like Spock. We can see neck pain, stiffness, things like that, but those are fairly rare. I haven't had anybody have a drooping eyelid or eyebrow or anything like that. We are breaking the skin given the injection, so there's a small risk for infection, but overall, again, it's pretty well tolerated. It is expensive. Insurance is generally pretty good at covering it, but it isn't something that I know I could afford just paying for it out of pocket. And so it's pricey if somebody was trying to do it without having insurance. It does require a prior authorization. And we need to see failure on some of the traditional meds, but I think we'll talk about that on the next slide. The CGRP monoclonal antibodies or antagonists are out as well. So these are medications like Aimovig, Ajovy, and Emgality. They have been out. Aimovig will be 3 in May, and the other 2 will be 3 in October. So they're just over 2 years old. The 3 that I listed are once a month. They're auto injectors, so you give them to yourself. It comes in a device kind of like an EpiPen. So you take the cap off. Most people give it on their thigh, press the button, and it does its thing. A few of them come in a traditional syringe and needle type style, but generally speaking, insurance is fine with the auto injectors. Ajovy does have an every 3-month option as well. The other 2 don't. These are also very limited with side effects. There can be injection site reactions. You could become allergic to them. We can see muscle cramps. Constipation is on Aimovig's label, but not on the other 2. And so they tend to be pretty clean. They're also expensive and require prior authorization. Most of the time, we can't get these approved if you haven't been on some other medications. And then there are a couple of acute medications that are out as well that are, again, targeting that same protein binding. So Nurtec and Ubrelvy have been out for about a year now. And they've, like I said, been a nice tool. There's not many side effects with those either. Nausea, potential allergy, drowsiness, dry mouth. So, in the grand scheme of things, that's not a huge risk with them that we know of. As far as the preventative medications go, they're a good option, but they're not perfect. Kind of generalizing the 3 medications, all 3 of them set up their studies or their trials a little bit differently. So I'd say that generally speaking, about 50% of people have about a 50% reduction in their headaches. maybe 25 to 30 or 40% would have a 75% or more reduction. And then there's a smaller percentage that have complete resolution of their headaches. And that's more with episodic migraines. So the 4 to 14 a month. With chronic, we see about maybe 30 to 40% of patients have a 50% or more reduction in their headaches. So, again, they're not perfect, but they are a nice tool that is fairly new, and they work really well for certain patients. As I kind of alluded to on our previous couple of slides, insurances aren't going to pay for these medications if you haven't been on some of the more traditional drugs in the first place. So they generally want to see failure on at least 2, sometimes 3 preventative medications. Some insurances are okay with 2 preventatives and 1 of the abortives, like Imitrex or something. Topiramate is an anticonvulsant. It's one of the seizure drugs. Propranolol is a older beta blocker or blood pressure drug. Amitriptyline is a tricyclic antidepressant, and so those are again some of those kind of traditional meds that if you look in a textbook, they're going to be the first things listed to treat a migraine. Certainly, if you feel like you need to be seen by our office or think you're at the point where you need Botox, talk with your primary provider. We can get you in for, or you'd need a referral, and we would work in a normal referral process. But if it's something you feel like you're ready for or you need, we would be happy to see you. If you want to look up any more information about what we talked about, medlineplus.gov is a good place to start for reliable information. It's funded by the National Institute of Health, so we all pay for it with our federal taxes. There's a little search box at the top, and it cuts out commercial bias, so you're not going to get hits from drug companies trying to sell you stuff. It's going to cut out just bad information. There's plenty of just downright bad info on Google, so it's a good place to look things up if you want. All right, looks like we've got some questions in this box. So how does Botox provide relief compared to other pharmaceutical meds? So I guess I kind of already talked about this. We don't 100% know, but it's probably acting on a cellular level, preventing some of those pain blocking. It may have some muscle relaxation stuff, probably acting on the CGRP receptors. So there's different things. I guess kind of backing up a little bit, anticonvulsants probably prevent that cortical spreading depression I mentioned. So that's how those probably work. The antidepressants are acting mainly on serotonin and its receptors. So those act specifically with the serotonin that we talked about before. And then beta blockers and other blood pressure drugs have some vasoconstrictive properties and some other things that are probably affecting those blood vessels themselves that are affected by the inflammation. So let's see, what are some natural preventatives, herbs, minerals that can be tried, i.e. feverfew, butterbur, magnesium? So yeah, there are certainly things that are natural that have been around for a long time that people have used to treat headaches. With a lot of this stuff, we don't have large scale randomized controlled trials like we like to see when we're making recommendations. There's unfortunately, not big money or federal grant money for people to study this stuff. So we don't have great information about it. But there are small scale studies and some, case studies and things that support the use of some of that stuff. Feverfew and butterbur have been used for a long time. They do have potential side effects. They can interact with other meds and things like that. So it's something to be mindful of. Magnesium has some pretty good information out about its use. A lot of times with pregnant women, if they're dealing with migraines, we'll recommend magnesium because it's safe in pregnancy. All the other stuff that we would use to treat migraines, I wouldn't feel comfortable prescribing to a pregnant patient. Riboflavin, or B2, is another one that I'll a lot of times use in pregnancy. There's some information that CoQ10 can maybe have some benefit. As I said, when we were talking about the non-pharmacologic stuff, warm and cold compresses. I don't think I listed it, but things like acupuncture, acupressure may have some place, massage, meditation, taking a nap, yoga, stretching, managing stress. There's people who sometimes report ginger can be helpful. I've had patients tell me they use essential oils, and I don't have any sort of recommendation in that regard, but I've had people claim that that helps their headaches. Worth noting that some people, as I said before, can be triggered into a migraine by certain smells. So potentially if you pick the wrong thing, it may make your headaches worse. Can you explain the difference between having headaches almost daily and having a migraine with aura on occasion? I get both. I'm curious if you can treat them in the same way. So yeah, I guess kind of in that discussion of chronic migraine, we can see multiple headaches going on at the same time. We can see, you know, a episodic migraine, and some people have a mixed headache syndrome where they've got tension headaches and migraines, or occipital neuralgia and migraines, or multiple things going on at once. That's certainly a possibility. Sometimes it is all just, you know, part of the chronic migraine picture that we can see, and it's all one thing versus, you know, two different things. Sometimes we see people who have migraines and they've been using too many medications, so they've got medication overuse, headaches happening daily, and then they get more severe migraines on top of that. So there's different things that can be going on, and so I don't know specifically in your situation, but as far as treatment goes, again, it kind of depends on what the two headache syndromes are, and if it's all migraine, potentially, you know, treating it may be effective. If it's medication overuse, stopping medication overuse makes them better. If it's a different headache syndrome, treating that accordingly. And there is some overlap, you know, with a lot of these medications. So we kind of specifically were talking migraine, but a lot of times there's benefit with some of these other drugs as well. Can alignment issues cause migraines and sensitivity to light? I suffer from spondylolisthesis and severe scoliosis, and often wonder if they're connected to my migraines. So they can be. You know, as I think I said earlier, there are you know, the trigeminal nerve kind of sits up in the neck, and so if there's a misalignment, it may make headaches worse, or it may provoke some of those headaches. You know, some people get relief from headaches getting adjusted, and so yeah, I mean, there could be some correlation with alignment and the headaches. The sensitivity to light that's mentioned is a symptom of migraine. So if they're triggering your migraines, that sensitivity to light is a symptom of migraine. And then Deb, my office manager here, mentioned that there is a reimbursement program through Botox that can help people if they do have to pay out of pocket for it. So that is a good point. You know, there are some times when there's insurance issues, and so there is assistance available through the drug companies for both Botox as well as the CGRP medications, or if you've got like a high deductible health plan where, you know, you've got a $7,000 or $8,000 deductible and you've got to meet that before they'll cover it. They can potentially help with that. And she put in here that they pay up to $1,000 per injection. So, and that's all stuff that, you know, if we need to, we've got staff in our office that can help with help with doing that paperwork and getting that set up for you. Is one medication better than others for someone who is triggered by weather changes? Not necessarily. The same process is basically happening. The weather change may cause it, but as far as I'm aware, there's not any specific, recommendation for patients with headaches that are just weather related. So yeah, looks like we had another one. What can I do to help with diagnosing chronic headache versus migraine? Journal my daily pain and symptoms. Is there food allergy trigger testing or other tests? So yeah, for anybody who is dealing with headaches, it's a great idea to keep a journal that helps us in treating the headaches and you in kind of knowing if the treatment's working. A lot of people, if they're having, 15, 20, 30 headaches a month, it can be hard to really know if anything we're doing is helpful, and keeping a journal of them or tracking them is beneficial, because then you can say, well, in February I had 18 and then we gave you X, Y, or Z medication or did this change, and maybe in March you only have 8 of them, and so 8's still a lot, and that's still hard to deal with, but things are a little bit better. There are multiple headache tracking apps that exist, as there's apps for everything, and most of them are free, or there's a lot of them that are free, and they can let you put in your symptoms, if it was, if you treated it effectively, how long it lasted, that sort of stuff. I don't order food or allergy trigger testing. As far as I know, there's not specific testing for triggers like there would be with food allergies. Most of the time when we're talking food triggers, I try to have people just eliminate the common triggers and see if their headaches get better, and then they pick their favorite foods and add them back in one at a time. So if you love chocolate, you add that back in, and if sure enough you get a headache after eating chocolate, dang, you got to avoid chocolate. But then that's a way to kind of rule them in and out. But I don't know that there's necessarily allergy correlation with that. It's more kind of substances within the food that contribute to it. Any other questions? All right, so there is a survey. The email, or you'll get an email sent out to email you're registered for. So if you could fill that out, that would be awesome. And I appreciate everybody's time tonight and joining me, and I hope it was informative and helpful.